So mine is a bit fancier than yours, but maybe it's lovely, I must say. Is yours gold or silver?
Gold.
Oh, I'm silver. I'm just
since I don't have anything like that, I'll just put you live on Facebook and I'll just leave the building. Right, bear me a second, I'm just going to put you live.
Thank you. Good afternoon, David. Last time, no crying, no tears. Good afternoon, everybody who's in the room with us and everybody on Facebook. A warm welcome to Dave and I's last, I don't know what you want to call it. We're Jeremy, Carolyn, Julia Hartley Brewer, something like that, are we?
Well, I guess so. Actually, I guess so. Although I'm still going to be around. Back it's for those of you who thought this sort of nonsense that comes out from me. We decided that as a celebration of Colette's last Thursday afternoon session, that anybody who had a fancy medal should wear it. And that's unfortunately Alan's been a bit left out here.
You're live on Facebook now as well.
All right.
I'll just go and get my Blue Peter badge. That's about the best I can get to join you guys.
I have to tell everybody, I once won a research medal, a research medal called the Sheila Sherlock.
No,
I didn't know it was another one. But the British Society of Gastroenterologists have an annual research medal, which I won one year for PBC research. And it's this sort of big gold medal, and I got it when my kids were quite young, and I found one of them trying to peel the silver foil off it. Because it thought it looked like a giant chocolate penny.
Oh, they could have given you the real gold. Welcome everybody on Facebook. As you will see, Professor Jones and I are wearing my MB and his OBE, both for services to PBC, which we thought we would share with you on our last day. And I'm delighted it's David here on my last day. We're going to have fun. Now, I've got a whole list of questions, David, so I hope you're sharp today. We've got one on the screen. Somebody saying it's fascinating to have a glimpse of the work. Enthusiastic delegates to the conference last week. Can you share an exciting new thing you've learned? I said Robert is on that. But if I were to share something, I would say to you, it looks like we're going to have three-line treatments for everybody. It was fantastic. Doctors were receptive, but Robert will keep you up to date with that. So we're going to go with this question.
Can I just comment on that? I think it's a really good question. So the meeting everyone's referring to is the European Liver Conference. So twice a year there's a big liver meeting, and it's very interesting to observe the mood amongst the people there. So mood, you can sense evolutions. And I sensed a big step change in kind of how people thought about PBC. This is my feeling from all the various different conversations. So the two things I really noticed. One is absolutely all the talk is about symptom control. How do we do it better? Which to me and to you is music to our ears, because we have been making that point for so long. So now it's about what do we do, not, do symptoms exist, that rather tired discussion. So that is real progress. And then the other is all the talk is around, can we cure PBC? How do we move to giving better, earlier treatment, which is, again, something we've gone on about. So PBC had a very high profile. There was the meetings around PBC were very well attended. That's not always been the case. And so I think it really does look good for the future.
And I'll very quickly say thank you, David. On top of that, one thing that struck me when I did that symposium with you and the four professors, and for everybody, professor from Germany, Italy, Spain, and David. And what struck me was how they said, that it's very difficult for them when they feel they can't offer anything to help with the symptoms. So it was another sharp reminder that, doctors are human beings, and it's not something that they like to, it's not a nice position for them to be in where they feel they can't do anything to change, make you feel better. So that was a real nice, sweet one for me. So Caroline's asking, can vitamin D levels affect your alkaline phosphatase results? A normal vitamin D and calcium level has coincided with decrease in alk phos numbers. Taking Adcal since September 2021, Ursula Walker, 42 years respectively. Is there a link, David?
Oh, that's a really, really good question. So there are two potential conceivable links. So that is a good question. The first one is generally about vitamin D. So generally speaking, vitamin D levels are low in everyone we see, but they are low in most of the UK population, and that's because of the weather, and because the fact that we spend too much time indoors, and because in particular when we go outdoors now and go on holiday, you put factor 50 sun cream on, and we make most of the vitamin D in our skin from sunlight. So vitamin D deficiency is very, very common in our population, interestingly. The reason why the specific question with PBC is fascinating, because there are actually two potential links for ALK Phos and PBC. The first is that, of course, alkaline phosphatase is also released by bones. So people with bone disease can also have a abnormality in their alkaline phosphatase. Okay. Now it's usually osteoporosis, which is silent with regard to that, but it sometimes can be more significant than that. So the first possibility, I mean, at the end of the day, if your ALK Phos has gone down just at the same time as you take vitamin D, it's either linked or it's a coincidence, and it's trying to work out which of those it is. So the first one is actually bone, and that the calcium is improving the bone, which is possible. And there are ways you can look for that by looking at the different types of alkaline phosphatase. The other one is the fact that everyone thinks of vitamin D as being a way of sort of controlling calcium and making bones, but in fact, vitamin D is a very important chemical for regulating the immune response. So it is actually involved in immunity, and it's perfectly possible that vitamin D level changes actually have an effect on the disease. It's never been properly studied, and it's an argument for getting vitamin D normal in everybody, but it will affect the way the immune response works. I think it's a really interesting one, and I think it's the sort of thing that the foundation can answer with these wonderful surveys that have actually shed so much information. I think if people have also noticed a change in their blood tests around about taking vitamin D, then I think it's something we'd really like to know about, because it's conceivable, but I'm not aware of any evidence on it at all. But that doesn't mean it isn't happening. It absolutely could be.
Okay, brilliant. Right, on to the paper version now. Wee bit background: I have my appointment with my hepatologist 18th of July. I am AIH/PBC with grade A cirrhosis. I do have all my tests to hand. I'm positive on AMA, SMSA, still waiting. FibroScan was 24, FibroScan was 24/7, and only ALT and ESR highly elevated at this point. I read that with these results and cirrhosis presence, hard to follow up the AIH treatment. In the meantime, a GP prescribed Urso that I'm presently taking 500 grams once a day, but my ALP is never elevated. I was doing my blood tests every year. Has anybody experienced or had anything similar in regard to the test and condition? If so, what approach would you recommend? This is quite complex. I think we need to keep this quite simple.
Yeah. So it's really important. So there are the potential for overlap between PBC and autoimmune hepatitis is definitely there, and you do see people who have both of them. However, and this important however, is it probably was overdiagnosed in the past, because some of the blood tests that we always used to think were part of autoimmune hepatitis were in fact part of the bad form of PBC. So essentially, the blood tests and the biopsy appearances could either be bad PBC warranting obeticholic acid, or they could have been associated with autoimmune hepatitis. Now that really matters, because it determines which treatment you have. So if it's an element of autoimmune hepatitis, then people will have steroids, natriuretic and things like that. If it's bad PBC, obeticholic acid or bezafibrate. Now it makes a big difference. Over the years, too many people have had steroids with PBC and have ended up with steroids. And we talked about bone before, osteoporosis because of steroids and PBC, a bit of casual thinking about it all. So we've got to be very careful with that. However, if somebody has both AMA, which is the PBC antibody, and SMA, which is one of the autoimmune hepatitis antibodies, it's much more likely that's true overlap. Okay, so that does start to sound a little bit like it is true overlap. So it certainly does occur. If you have both, you treat both, and that's really important. Now, some people it's predominantly autoimmune hepatitis, some people predominantly PBC, and you do need to be aware of that. But the principle is you want a normal ALT, which is the autoimmune hepatitis bit, and you want a normal alkaline phosphatase, which is the PBC bit, and you need to treat both. My only comment about the numbers that Collette read out is that an URSO dose of 500 milligrams a day is never going to be the right dose. Is never going to be the right dose. It's 15 to 15 milligrams per kilogram. And the rule of thumb with overlap is if you've got both, treat both properly. Usually it's a case of getting the right PBC treatment on board, which will be, usually it's about 750 to 1500 milligrams a day of URSO, and then you look at what's left after that. But 500 is regardless of anything else, too low. And I think the one thing you don't do is if you think they might have overlap, kind of half sure they've got a PBC element, you don't sort of half treat it. Do you know what I mean? Is that if you're going to treat it, particularly with URSO, where there's no side effects with it particularly at all. So this true true overlap does exist. If the SMA and the AMA are both there, it increases the likelihood it is true overlap. So treat both and treat both properly.
Excellent. Okay, thank you, David. 4 months ago, tested negative for AMA, and then 2 weeks ago, positive. Then they redo the test. Tonight, my results came back negative. I haven't spoken to my hepatologist. I was diagnosed solely based on the AMA test. All my liver function tests are normal. Yep. No symptoms. My ultrasounds and fibro cancers are normal. So there's 2 questions together, so I'll read it all out. So the first question, could the AMA show positive, then negative 2 weeks later? And then she goes on, she says, my understanding is I need not only a positive AMA, but elevated liver test or biopsy to be diagnosed. But the doctor diagnosed me from the AMA and started me on URSO. I'm so confused whether I have the disease or not. Based on the above, do I have PBC or not?
So the answer is it's very difficult to tell, because if somebody's got normal liver biochemistry on URSO, you don't know whether they've just got normal liver biochemistry or whether the URSO's made it normal. Okay. At one level, you've sort of got PBC because it's being treated. Why would you treat a disease you didn't have? And so this is a discussion we have with people all the time, that there are some people who are marginal for treatment because the diagnosis is kind of could be, couldn't be. The thing is that once you treat it, you've kind of agreed the disease is there, haven't you? I mean, and so you do sort of cross that line. Now, AMA does not normally fluctuate. Okay, it doesn't normally do that. So it's a bit binary. You either have it or you don't. And if you have it, you have it forever. And if you don't have it, you don't have it forever for most people. And that even applies after a liver transplant. So people who have a liver transplant will still be AMA positive. It just doesn't tend to go away. So if it is fluctuating, it means one of 2 things. One is that it is a sort of oddity around their testing. So we have a sort of saying about tests: what you find depends on what's at both ends of the needle. So there are confirmatory tests, and if you're getting an odd pattern like that, you do wonder where the truth lies with it. However, if it is genuinely fluctuating, then almost certainly is a false positive, because the immune system produces all manner of antibodies normally, and the levels go up and down. It's a bit like rising and falling tide. They go up and down depending on how activated your immune system is. And what activates your immune system is all the viruses you've bumped into, what you've eaten, et cetera, et cetera. So if somebody is marginally negative and marginally positive and marginally negative, it suggests that it's actually noise, that it's that an antibody your immune system just produces, and it's sometimes measurable and sometimes isn't, depending on the kind of how the thermostat is. Now, why not? So we see a lot of people who do have AMA consistently over a long period of time and do have normal liver function tests over a length of time, and we would normally not treat them. Okay, they have what we call pre-PBC, they have or a early form of a PBC spectrum condition, because they have the antibody which is associated with PBC, but they don't have the features of PBC. So normally we would advise people there is a risk. The risk is relatively low. Somebody needs to check blood tests every year and be aware of them. And if you develop abnormal liver biochemistry, then you treat with urso. That's the standard advice. The two situations which I would do that differently are, one, if somebody had a bad family history. So if mum had had a liver transplant and you've turned up for PBC and you've turned up with an AMA, then I can reassure you all I want, but your personal and family experience is that this is quite a tricky disease. And so in those situations, I lay it out there, and it's entirely up to people whether they want to be treated or not. And it's about half and half. Half elect to be treated, but half elect not to be. And I think you can argue it both ways. The other situation is where people have PBC symptoms, because we do know that some of the symptoms of PBC, particularly itch and fatigue, can be seen in people who've just got the AMA. So we do in our symptoms clinic see a number of people who have been investigated with an AMA because they've got symptoms. And in those situations, I always feel that they have clinical features of PBC, so we would discuss treating with them. So the only people with AMA positive and normal LFTs that we treat are people who either have symptoms or they have a kind of scary family history. Okay. What's the downside of treating? Why not treat everybody? Well, the majority of people don't need it because most people who are AMA positive don't develop PBC. And of course, the weight gain and the hair loss, and actually, although I've had hair loss and weight gain, I don't do so. So you are taking a tablet which isn't benefiting you, so that's a downside of it. Potentially with some small side effects. But the main issue is that in terms of insurance companies and things like that, you've kind of got PBC now. So you can't really say I'm being watched because I've got pre-PBC. If you're treating it, you've either kind of, if you only treat people with high blood pressure, you treat people with high blood pressure because you've got high blood pressure, not because you might get high blood pressure. Do you know what I mean? So I think if you are on treatment, that line's being crossed, and I would just continue with it. It does no harm, and you'll never know whether you'll probably never have problems, and you'll never know whether you needed it. But that means you've not had PBC over a long period of time, which is kind of a good result. There is a case for treating everybody. We tend not to, but we treat probably more people than most people do. But it's usually one of those reasons.
Brilliant. And this kind of feeds into the next one. You might not actually need to answer because I think you've covered quite a lot there. 43 years old, 6 months ago, was diagnosed with stage 3 fatty liver with NASH. I went on a clean diet. I'm not sure what clean diet is. Lost 50 pounds. Fantastic. Well done. And reversed my condition. Excellent. Same thing. I was diagnosed with PBC. I solely on a positive AMA. My liver numbers are perfect. Ultrasound fibre scan are all normal. My doctor asked me, I know, are so based on the positive AMA. I've got a feeling this is American, but I don't know. Is this standard treatment the positive? Well, you've really answered that. I understood that positive AMA with no symptoms does not necessarily mean you have an active disease. You've explained that. Does a positive AMA mean you'll develop PBC at some point? And I think you've kind of answered that as well. Would you feel?
Possibly not.
Yeah, great, good, right? Because we have got a big audience today, Professor Jones. We've got a lot of people in. Has anyone heard or taken Heptral, manufactured by Abbott for PBC or AIH? Heptral, Heptral.
Let me just check what that is.
Yeah. I've got a feeling this may be non-British. I don't know.
Hang on a second. Heptral. What is Heptral? Heptral. Heptral is one of the brands of S-adenosyl methionine. Okay.
Well, I can't say that. Right.
S-adenosyl methionine. S-adenosyl methionine. It used to be known as SAMe. S-A-M-E. Okay. SAMe, S-adenosyl methionine, is the first drug I ever took part in a clinical trial about. Okay. So it was being argued for as a treatment to prevent the risks of cirrhosis. Okay. And a number of PBC patients, this is 88. I know I don't look old enough to be doing trials in 88. I was doing them at school. Okay. I was at school still. So a number of PBC patients took part in this trial, okay, and all of them said it really improved the symptoms of PBC, okay. But they weren't measuring the symptoms of PBC in the trial because that was the dark age when you didn't do that, and so it was just out there in the kind of, you know, never question that was never answered kind of category. In about 1991 or 2, there was a really big trial. In fact, the biggest ever trial of fatigue in PBC used Heptrel, not that trade name, but S-adenosyl Adamet, we tend to call it, S-adenosyl methionine. And it showed that it significantly improved fatigue in PBC, okay? And it's a study that's almost completely forgotten about, although not by us. Almost completely forgotten about, but it is the largest ever trial of fatigue treatment in PBC, okay? If you go to Eastern Europe, they use Heptrel widely to protect the liver from chronic liver disease. So it's available in the former Russian states, and it's widely used. And it's actually been trialed by Piotr Mikulovich, who you'll know, in Warsaw, very good PBC doctor, friend of mine. He's done a trial of this, which shows biochemical improvement and symptom improvement, both itch and fatigue. And there's some real world data from Ukraine. I know colleagues in the Ukraine and you know, who have been badly affected by the things that are going on there. And you know, we do work with them, and they've also used this drug. So there's actually a lot of evidence it's beneficial. Now, we have been trying to work with companies for years to persuade them to do a proper trial in the 21st century using current PBC measures. And as a sign of my devotion to try and persuade them to do this, I went to do a meeting with them to explain the potential benefits. And that meeting was in Wuhan in January 2020. Wow. So there you go. That's what I do for the cause. Wuhan in 2020, near the food market. Okay. So we really like Heptrel or S-adenosyl methionine as a therapy. Our new symptoms clinic, we have a vitamins and supplements guidance sheet we give out to people, which I'm very happy to distribute through the foundation, just some guidance. And we now include this on it. And the reason we include it is that it's now available in the UK and it wasn't before. So it's one of these odd things. It's covered by vitamin rules. And of course, they're not pharmaceuticals, and they're kind of food supplements. And the regulations about them are really strange. So some ways it can be more difficult to bring vitamins to market than it is drugs. It's weird. So S-adenosyl methionine is only licensed in Italy, but you can buy it in sports shops in America because it's you know, helps with exercise training. Anyway, the long and the short of it is that the internet allows vitamins to be imported effectively, so it is now available, and I know a number of our patients are taking it, and I will be absolutely fascinated to find out their experience. So it's an oddity, it's a curiosity. It has more evidence to support its use in PBC for symptoms than any other drug, but it needs proper trials. But if you can get hold of it, then it's a very logical thing to take because it has actually got good trial evidence. There you go.
And I think if anybody is doing that, to let the consultant know that that's what they're doing. Is that reasonable? Yes. Absolutely. Yes. Okay, so I'm going to answer part of this, and I'll do it very quickly. I've discovered that PBC can affect the lungs. Well, no, PBC affects the liver. That's a different, but David will answer that. Can you give me information? I've heard that boomer bust in activity can be dangerous. Can you provide any guidance on pacing oneself and not overdoing it? Yes, but over the airwaves, it will be difficult. Give us a phone at the office. No such thing as boomer bust. You do pace yourself. We individually know how to do it, but happy to talk you through it. Movement is absolute medicine. It is good for you, but there is no boomer bust. So, David, I've had PBC.
Lung disease, right? So PBC can be associated. So you don't get PBC in the lung, but you can get a couple of lung problems kind of associated. So there is a bit of an association with lung fibrosis. So scarring in the lung can be more common in PBC patients than in other patients, although it's not common. And the other one is pulmonary hypertension. So we tend to think of hypertension being high arterial blood pressure, you know, when you feel your pulse. but of course, there is another set of arteries which take blood from the right side of the heart to the lungs and back, and then back into the veins, back to the heart. And of course, you can't measure the blood pressure very easily like that. And when that pressure is high on that side of the heart, then it causes lung problems. So we think that pulmonary hypertension is a little bit more common than it perhaps should be in PBC patients, although again, not common. So if people are short of breath with PBC, then actually it warrants investigating. It needs two sets of investigations. One is what we call pulmonary function tests, which are where you do breathing tests, and that measures very different aspects of how the oxygen gets into the blood. The one thing isn't associated with PBC is asthma or COPD. Okay, so the old-fashioned spirometry, where you blow really hard on a tube, that's not the most useful test. It needs to be more about how the lungs work. And then the other thing is a thing called echocardiogram, so an ultrasound of the heart. And what that does is allows them to measure the pressures around the heart. So an echo, we call them echoes, an echo and pulmonary function tests are very useful. In terms of exercise and boom or bust, you'll have good days and bad days. That's pretty much universal in people's experience. That's the first thing. The second thing to say is that you will usually be better in the morning and then you'll kind of get worse during the course of the day. That's totally normal. But the third thing is you do not hurt yourself by having a bad day or pushing yourself a little bit because you've got something to do. It does not cause harm. In fact, quite the opposite. As Collette says, movement is medicine. It helps tune the body. So you want to go to just the point where it's too much for you right then, and then stop doing it. So do keep challenging it. You can train yourself up in simple terms. Now, to link that up to the last comment about S-adenosine, okay, I'd said that it's sold in sports shops in America. Now, when you exercise, you cause muscle damage because of the effects of acid in the muscle. And we know from some of our research that PBC patients get too much acid in their muscles. And that's one of the reasons why people feel tired. And there's a thing called glutathione. Nobody knew they were going to get a biochemistry lesson today, but hey, here we go. So there's a thing called glutathione, which is a vitamin which you need to have in your muscles to allow them to work healthily. Okay. And there was a guy in Manchester called Tom Warnes, and there may be people on the call who were under his care, very good PBC doctor a number of years ago. And he did really good, you remember him? Yeah. He did some really good work on vitamins in PBC and showed that this thing, glutathione, is almost absent from PBC patients. It's just not there at all. And that means your muscles are exposed to all of this injury. Why does any of that matter? Well, it's quite difficult to give people glutathione, which you need to supplement back to let your muscles work. But if you give people Heptral, S-adenosine, it gets turned into glutathione. And that's how we think it works. So if you take it, most people can exercise a little bit more, which means that then they'll get a little bit fitter, and then tomorrow they'll exercise a little bit more. So actually these vitamins and exercise it's not one or the other, they tend to go together.
I would add something to that, if I may, please, David, that we did a webinar yesterday, and we spoke about what goes on in Newcastle in terms of movement medicine and how you came across this.
Yes.
And I'd say to everybody, when I was first diagnosed, I was told to rest. The more I rested, the more I slept. So anyway, eventually some years ago, I started getting out of my bike. I used to cycle a lot in the summers, and I used to cycle with Chris. But, winter time, winter's winter, we don't do as much. Then come the summer again, out with the bike, and I'd have this huge problem with lactic acid. I have to get off the bike, stretch off. Motorists passing me in the street saying, "Can I help you?" thinking I was in great distress. It was a constant problem. It was beginning to put me off going out in the spring, summer on my bike until I got a dog. When I got a dog, so I'm walking 4 or 5 miles, whatever, every day, all through the winter. But it was a continual exercise through the winter. So the time the bike season came, I wasn't suffering any of the lactic acid problems. So really the message I'm saying, I'm sure you'd agree, David, that is be consistent. Don't have chunks and months where you don't do anything, because the lactic acid built up all over again. And now I don't have any problem whatsoever, none. And it's fantastic. I love it. Okay.
Correct. You're better to do So lower levels sustained over a long period of time. That's the sort of boom and bust I wouldn't do.
Yeah. Right. I missed out a couple because they're general. If we've got time, I'm going to come back to them, but I will ensure that we will have articles in the newsletter. And I think we already have, actually. I see they have a treatment for scleroderma that is helping stop the autoimmune system from attacking itself. Could this also work for PBC? I'm not sure what the drug is, David.
Yeah, so scleroderma is a variant of systemic. It's another name for systemic sclerosis, which is another of the autoimmune conditions, and it is associated with PBC. Although the combination is rare. I mean, scleroderma is rare, PBC is rare, so that the combination is actually pretty rare. It's just a bit less rare than it ought to be. So scleroderma, it's very interesting. So there are particular immune conditions that are associated with PBC, and scleroderma is one of them. And there are others that really aren't. So, for example, type 1 diabetes, which is the one that affects young people, where they go onto insulin relatively early. That almost never affects people with PBC in our experience. So some are, some aren't. So scleroderma, and they give a variety of treatments, traditional ones and then sort of emerging ones, to modulate the immune system. Now, PBC, the immune system is part of the disease, but only part of it. And so a number of these drugs have been trialed in PBC, but they work variably. And the reason they work variably is because the degree to which it's the immune system that's abnormal in PBC varies from person to person. So whenever people are planning management for something like scleroderma, there's a dialogue that goes on between the rheumatologists who normally look after it and the PBC doctors to find a regime that, if it's going to work for both, will work for both, and the flip side of it, avoid something that's going to make PBC worse. So you do need to make sure both are covered. So there are a number of therapies given for scleroderma that undoubtedly may well be beneficial for PBC. However, we tend not to use them in PBC because they may well not be beneficial to other people or even harmful. So it's one of those ones where you see what happens with individual people, but absolutely they have the same common root around the immune system being overactive.
Fantastic. It's nice. It's good to know, actually. So very quickly, I've been diagnosed with lichen sclerosis and I've been prescribed topical steroids. Is this condition common in people with PBC?
Yes.
Okay.
Yes.
Right.
So there are a number of, so it's inflammation of the skin. There are various different variants of it. It's another of these immune overactivity things. And of course, the advantage of skin problems is that you can use topical treatments. So they will always look to give topical treatments. The other thing they do quite a lot of is light therapy, because light modifies the way skin behaves. So one of the skin inflammatory conditions tend to be treated in a very different way, for the simple reason you can reach them with ointment and things.
This particular one happens to be in the person's mouth and private parts.
Yeah.
So that is treatable, right? Okay, so I know she was worried about it. Okay. Can a cholecystectomy trigger the autoimmune response resulting in PBC in susceptible people?
Can cholecystectomy trigger PBC?
Yeah.
No, not in my experience. It's the other way around. PBC makes people more susceptible to gallstones. So my best guess in that situation is, if somebody has gallstones and is then found to have PBC, they probably had PBC all along, and it was only actually looked for after the gallstones were taken out. So they are linked, but it's the other way around. PBC will have predisposed to gallstones.
Yeah. This one's probably more a statement than a question. Diagnosed PBC a year ago, took lansoprazole, an anti-stomach for acid reflux, then took my urso, later with breakfast. After 6 months, the alkaline phosphatase had gone up, that's right. I thought the drugs might interfere with each other, taking them so closely. I started taking them at lunchtime, and in the evening, I started taking the urso at lunchtime, and in the evening, my alkaline phosphate reduced. So I think there may be something in this. So it's badly taken out. So they're taking big separation between the omeprazole and the urso. And does it make sense to take the urso quite a bit later, away from the lansoprazole and urso, as I have not previously been advised to keep them separate, and it seems to have benefited me and may help others. So big gap in time between urso and separate.
Yes.
So
Yes.
you happy with that?
Yeah, what do I think? So some drugs interact with other drugs, okay? Not in a harmful way, but they minimize the effectiveness of them. So some drugs interact with other drugs and some just don't really. So the one that we always worry about is urso and questran, because the two bind together, okay? But one of the drugs that notoriously interferes with other drugs is lansoprazole, okay? So it's famous for it, but it doesn't work as well, and the other drugs don't work as well if you take them together, okay? Now, it's bizarre because omeprazole, which is the other one of these...
The older one, isn't it?
No, they're fine. Omeprazole is fine. It's just lansoprazole.
It was an older drug, I think. It was one of the first.
Lansoprazole is famous for interacting with other drugs. So you have to take lansoprazole in the morning before you have breakfast or drink anything, and not take any drugs with it. So the easy answer, to be quite honest, is to give people omeprazole or one of the other ones where you don't have the problem. It's all done for information about price that is completely out of date. So these drugs are very cheap, and so we would just move people onto omeprazole, which doesn't have the effect. If you're staying on lansoprazole, if you're happy with that from an acid point of view, then I would just take the urso as you're doing, which is later in the day. And so if you have suddenly discovered that your control is better, control is better even though you take the same drugs, just because you take them in a different sequence, you're absolutely right.
Absolutely spot on. Brilliant tip there, David. Thank you. Paxlovid, when taking COVID, is it okay for the liver? Paxlovid, Paxlovid. I think it's an antiviral, perhaps.
Yeah, no, there are no concerns with them.
No concerns, right?
Okay.
And just be careful, everybody, by the way, with antivirals they're offering you if you do have COVID, because some of them interfere with blood pressure tablets. Talk it through with the person who's offering it to you. They'll put you in touch with a pharmacist or a consultant, which is what happened to me, and you'll make an informed decision.
Can I be very honest about the antivirals Please. With COVID?
Please.
The gains are marginal, okay? The gains are marginal. These are not game-changing drugs. You know, the reason we don't have a problem with COVID now, and we did have a problem with COVID before, is actually threefold. One is the impact of vaccination, which converts it back to a much more harmless virus. The second is we've all calmed down a little bit about it, and so it now isn't the end of the world, whereas it was thought to be the end of the world before. And the third is there's natural evolution in the virus to be less harmful. However, at face value, it's become less of a problem at the same time these antivirals became available. However, they are not, in my experience, game changers. Okay. And I think if you give them to 10,000 people, they offer, on average, a small advantage. However, to you as an individual, it's a different thing. So that nobody must take these. Okay, I think it would be illogical not to be vaccinated, but I think it's a marginal decision about these drugs.
Excellent. Diagnosed with PBC 5 months ago, responded well to urso. Excellent, fantastic. Just been diagnosed with TB this week, has not yet given medication. I'm so sorry. If prescribed steroids for TB, are they safe to take? Now, you may not be described that, but one's got to assume that these doctors are going to be working together as well, David.
Yes. So sorry, Miriam's just wandered in.
Hi, Miriam.
She's given me a whole pile of things to sign. People hunt me down with things to sign.
Found in a broom cupboard, have they?
Hunt me down. Right. Okay. So bad luck. TB never went away. Okay. TB never went away. There are sporadic cases in our population. It also reactivates in people, maybe if they had it when they were children, if they're a little bit older. So it does happen. It's very treatable. So it's a very treatable condition. The challenge is actually in diagnosing it. So probably people, because they're not familiar with it, people don't think about it anymore. I come from an earlier era of medicine, so we think about it, we look for it in people, and we find it, So it's very treatable with antibiotics, usually a combination given over about 6 months or so. Now, liver doctors are very aware of TB because there are some interactions, not with liver disease, but the drugs that are given for TB can cause liver problems. So all liver doctors are all aware of TB because of those issues. So they will be very aware. Those effects are, however, not additive. So PBC patients are not more at risk from the drugs, less risk from the drugs or whatever. So there's no link at all between PBC and the drugs, with one oddity of an exception. So the two don't interact, but your liver doctors will be very aware of all of this, and they monitor people taking TB treatment very carefully. So it's one of those things, you know, must treat it. It's one of those things, it's really, really important you take all the treatment, so resistance arises quite easily. So you will be given a combination, you must take them. The oddity, of course, is that one of the drugs that most regimes for TB include is rifampicin, which of course is a drug widely used in PBC for itch control. So rifampicin is only ever used in two situations in the world. One is for TB and the other is for management of itch with PBC. So you're kind of a bit unlucky. Anyway, rifampicin is probably the right thing.
But you know, I'm delighted, and can I say to this person, I'm delighted what David's saying, that there is a treatment for TB, because you would know this. My granny died of TB. She was only 33, David.
Yes.
She was 33 years old with children, and she died. Okay. I'm the volunteer for East Sussex for the PBC Foundation. And by the way, she died when there was no treatments. Volunteer for the East Sussex PBC Foundation. Hello there. I know who you are. Lovely you come in. Common question I get is, why do we itch in the evening, not so much in the day? Now, we're going to have to be brief because you have stacks of questions coming in, Professor.
Right, so I just broke up very quickly. What's commoner in the evening?
Itch.
Why is itch commoner in the evening?
And not so much through the day. And, well, we know that the itch is always worse in the evening.
So there is undoubtedly what we call a circadian rhythm to it, undoubtedly. So it is worse in the evenings and the night. And that's to do with the levels of hormones in your body. So sleep-wake cycle and things. So your body has a sort of program around timings, and it's why people go on night shifts really struggle, or you know, if you have constant light you really struggle because your body is programmed to do that. So the chemicals in your body just do go up in the evening that are related to itch. There is another reason, however, which is important, which is what else is on your mind at the time. So you can distract people away from having itch. So that if you have many other things that you are thinking about and doing, then you will be less aware of itch. That doesn't mean the itch has gone away or is less of a problem. It means that your brain has filtered the signal out. So your brain does filter signals out. So if you are lying in bed at night and there's no other signals going to your brain, then it will, you know, it won't filter the itch out. So you can sometimes be more aware of itch at night. So it is worse at night actually, but there's a double whammy. Sometimes people are also more aware of it, and treating itch in the evenings and the night is therefore very important. And if you're going to treat itch at night, don't think of taking something at bedtime, be taking something earlier in the evening so it's got time to work.
That's it. And keep bicarbonate of soda, have a bath, and bicarbonate of soda, they use it in the hospitals, and it does help you get a good sleep at night. I have more fatigue than normal, feel lightheaded, tingling in my feet, nausea in the mornings. Could this be caused by vitamin B12 deficiency? Should I get this checked? Let me say to everybody out there, you have different symptoms that aren't just there for a couple of hours, that are persistent. You must go back and get it checked. We get other things. We get anything else, everything else. Absolutely 100%. So it would be wrong for MD to speculate, but David, would you agree?
Yeah. So you know, the first paragraph of management of fatigue is to look for other conditions that can be associated, which will themselves contribute to fatigue. So folate deficiency, B12 deficiency, anybody with tingling in their feet who feels tired, you need to exclude diabetes. So there are a number of things you need to think about. Nausea can be part of PBC, lightheaded can be part of PBC, tingling in the feet would tend not to be. So it needs a castanet. So Collette is absolutely right. Before it is PBC fatigue, you need to be certain it's not just fatigue in somebody who happens to have PBC from a totally different cause. So, and you know, in a nutshell, that's why we have the symptoms clinic, to be able to take these layers through.
Somebody's put thank you, David. Somebody's put this question too, and I don't think we've got enough information. I would ask, but and I hope you agree that this person needs to come back. How can PBC progress when all bloods are near normal? PBC diagnosed 2006. What comes after HE? I really am a bit uncomfortable with this, David. Are you hearing me okay? Are you getting old? Need to put your ear to the screen. You got a trumpet thing. Can we ask this person to come back?
No, it's just use my better side, you know. Looking regal.
Regal. Well, we are regal today, aren't we? We're royal today.
Can I just say it does look better in gold? I hate to tell you that, but you know.
Everything else I'm wearing is gold. I'm a gold kind of girl. Should we ask this person to come back?
Yeah. I think there's a general point which I will comment on, which is that blood tests are an inexact way of working out what's happening in the liver. Okay. And I remember I've looked after many people who've had cirrhosis with normal liver blood tests. Okay. Now, and it's the difference, we keep talking about this, the difference between 1,000 people and one person. Over 1,000 people, then there were, on average, liver blood tests will predict what's happening in the liver. But the individual, it can be very variable. It's like, I always say, I'm down in my other office today, overlooking the football ground here. If you were to pluck one person out of the crowd at St. James's Park, is that person representative of everybody in St. James's Park, right? Well, it could be a fat Geordie with no shirt on, in which case, yes. Or alternatively, it could be the mum who's taken her children to go and watch the football. Is she represented the crowd? No. So, but if you take 1,000 people, then that will be a profile that will be representative. So you've just got to watch that. Liver function tests are a useful part of monitoring what's going on, but they only tell you part of it. This is why FibroScan is so important, because it tells you, if you think of one is the x-axis, the other is the y-axis. So the blood tests tell you activity and the FibroScan tells you severity. And you can have inactive but severe disease and mild but active disease, and you need to have both. So it's two-dimensional.
And I have to say, not everybody, not half, not whatever, go on to develop HE. There's not
hepatic encephalopathy.
Yeah,
that is,
I mean,
vanishingly rare in PBC. Vanishingly rare.
What different reasons would there be for severe? They're calling it edema. Body's very swollen and pressured from cells holding in fluid. Am I not just filtering it through my organs anymore? And this is quite complex. And I hope this person is being monitored with a hospital doctor. They're seeing you on a regular basis.
Yeah. Okay. So edema is fluid in the tissue. So you get it in various different tissues, but a lot of it is what we call dependent edema, which is swelling of the legs, ankles and legs. Okay. And there are lots and lots of different causes, ranging from having been on your legs too much, so people can get dependent anemia, you know, if they've been walking around all the day, all the way through to significant illness. So it's very difficult to give a view on that. So in cirrhosis, it can be part of cirrhosis, but most people with edema with PBC won't have cirrhosis. It's because it's quite uncommon. So it's quite a tricky one, and it is actually important to go through the diagnosis before you treat it. So the treatment is usually water tablets in one form or another, but you just do have to be a little bit careful. Yeah.
Okay. I have peripheral neuropathy. I think we actually covered this. Consultants test me to see if I have pernicious anemia. Is this common with PBC? Well, of course, it's quite common with PBC to have other autoimmune conditions, and some more common than others. I think thyroid is the most common, but probably wait until you get the results from your doctor.
So pernicious anemia is actually a particular association with PBC. So it is one of the ones that is a strong association. Not as common as thyroid disease, because thyroid disease itself is commoner. But pernicious anemia is one of the kind of commoner relative associations. And it's an autoimmune disease of the stomach, which stops you absorbing vitamin B12. And the treatment's really simple. You need B12 injections. So we would check a lot of people out for B12 deficiency, largely because it's really easy to treat and it's important not to miss it. So it sounds like a very logical thing to do. But just measure your B12, to be honest.
You know, my dog has it. My dog, she doesn't have PBC though, but she has a vitamin B12.
Has she got one of those little tartan dog coats that Scotland?
No, she's not. Her name's Holly Jones, actually. And by the way, I spoke to the owner of Keris Matthews. He's going to be confirming with you at your next board meeting. What is the difference between stem cell treatment and bone marrow treatment? That just might be an awful lot for today. Is it the same thing? As well as PBC, I also have systemic scleroderma, and I've heard those things might be an option for treatment. Well, we've kind of covered that.
Yeah. Okay. I laughed. What's the difference between stem cell treatment and bone marrow transplant? Okay, marketing. Okay, it's the difference between Snickers and Marathon. It's Opal Fruits and Pacers. It's Sellafield and Windscale. Right.
Okay.
Bone marrow transplant has been reinvented or retermed stem cell therapy, and it's a little bit. So there are other, I joke, but there are other forms of stem cell therapy. But 90% of the stem cell therapy people get is good old-fashioned bone marrow transplant with marketing.
Right. Okay. So PBC, I have systemic scleroderma, and I've heard those things might be an option for treatment. Don't know if these are procedures or not. I know the UK does more of these treatments on the US and wondered what they are. Well, we've kind of covered scleroderma, really, haven't we? Yeah. Right. So where are we now? Next, I am AMA negative, PBC, and I've quickly progressed to cirrhosis with grade 1 esophageal varices, rectal varices. What would you advise me? Treatment on UCDA and bezafibrate. I'm awaiting a review. Great question.
Okay, so if somebody's AMA negative and has PBC, first question I would say is, how certain are you it's PBC? Because unless you had a biopsy, all you've got is liver blood test abnormality. So everybody with AMA negative PBC has a question mark against them until you have some other test that confirms it. And the reason that's important is because PBC therapy won't work if it's not PBC, and you'll miss the opportunity to get other therapies. That's the first caveat. So I would, in those situations, that's a situation in which you would biopsy. I'll be honest, because you cannot diagnose PBC in people without AMA or ANA without a biopsy. And actually, if you've progressed to cirrhosis, you need to get the best therapy you can. Now, there are some nuances about antibodies, so it's possible that one of the things you need to just be aware of is what we call Chinese whispers in diagnosis, right? So if you track back through people's notes, what you find is you'll see somebody who's been sent into the doctor saying, liver function test abnormal, not sure what it is. Could it be PBC? The answer being no. And the next time they come to the clinic, it's turned into query PBC, which it was. It was a query, have they got PBC? The answer being no. The next time the letter says possible PBC. Okay, so it's moved on. And then all the letters then give you increasing certainty until people have got PBC. And it's send reinforcements we're going to advance. It ends up with send reinforcements we're going to
advance. That's
the Chinese whispers where tentative possible diagnoses get reinforced. So it's really important. And the other thing is for people not to assume that somebody who fits the demographics of PBC has got PBC because they're a woman of a certain age. So I would question the diagnosis. Okay. Obviously, if somebody has grade 1, if somebody has cirrhosis and is beginning to get complications, then it's really important you do two things. One is to treat the disease as best you possibly can to stop the disease progressing further. So just because you've got early cirrhosis doesn't mean you don't treat the disease. It's even more important to treat the disease. And also then you need to screen for and manage the complications. But that's a pretty unusual story in PBC. So I would go the diagnosis. And if you've got a biopsy that says classical PBC, then great, you know what you're dealing with. But I would just flag that question.
To make sure. Just had an infusion for COVID. Presume it's okay for PBC in the liver.
Yeah.
Yeah. Okay.
Yeah.
Is iron deficiency common with PBC, especially low ferritin levels?
Yeah. So low ferritin. So ferritin is a storage chemical for iron. So low ferritin is a marker of iron deficiency. Okay. So iron deficiency, in simple terms, is because either you're losing iron or you're not absorbing enough iron, in simple terms. Okay. And PBC can be associated with both of those. So we see a number of iron deficiencies. So celiac disease is quite common, where people don't absorb iron. You also can get, some varices and things like that can cause blood loss. However, most blood loss is not PBC linked. And what you've got to be absolutely certain about, we've heard a lot of, stuff about bowel cancer and things like that. Deborah James and things like that, died of bowel cancer at 40. That usually presents with iron deficiency anemia. So it is really important, if you're iron deficient, that people don't put it down to PBC related things without being certain it's not. Trust me, nobody wants to have bowel cancer, but if it starts as a polyp in your bowel, that's easily removed at an endoscopy, and it becomes a real problem down the line. So it's well possible to be PBC. In itself, it's not a problem. A lot of people, it's periods or whatever, there are reasons why people can be iron deficient, but you do need to be certain it's not a treatable important cause.
Okay, brilliant. Would treatments for lupus harm people with PBC?
Would treatments, yeah, we talked about this with systemic sclerosis, actually. Yeah. Lupus is the other one that is rare combination but is associated. Okay, so the good news about both systemic sclerosis and lupus in PBC is they tend to be much milder than they are in people who don't have PBC, for reasons I don't quite understand. So there's an element, it's almost as if the immune system energy is kind of split a little bit. Yeah. So if you've got lupus or systemic sclerosis, then actually in many ways that's the treatment, that's the condition that's most important to treat. And so there is no therapy that people give for lupus that I would not give in somebody who had lupus and PBC. But the comment before about dialogue, to make sure that you have something that fits together. So for example, one of the treatments that gets used in lupus quite a lot is rituximab, okay? And rituximab has some real benefits in PBC. So there are some drugs where you think that's a smart combination. But if you have lupus or systemic sclerosis and PBC, then number one priority is actually treating the lupus or the systemic sclerosis. And the PBC will follow along behind and usually respond to the same treatments.
Okay. Are you still of the opinion, Professor, that taking Urso at night is fine as I take mine all at once in the evening?
Yes.
Okay. Diagnosed with PBC 10 years ago, AMA positive, liver stable, on Urso, fatigue always very bad. What do we currently know about the mechanisms that cause the fatigue? Well, David is working on that. David's actually going to be doing an article. But I think other than going to the mechanisms that cause fatigue, because we are hammered for time here.
Yeah, I think we're going to write some stuff on it. I think watch this space. There's a lot of science coming out about this. We're understanding much more about this than we used to, and there will be therapies coming along. So suffice to say, it is part of the impact of the disease on people's brains. Yeah. It's a real condition. It's real.
Okay, yeah, absolutely, it is. Are you okay for time, David? Or
I have a hard stop at 10 past.
Right, okay. Due to have surgery next week, thoughts on baby aspirin?
Thoughts on baby aspirin?
Yeah.
It doesn't have any, not for babies. Aspirin is contraindicated in children, but low dose aspirin for heart disease risk, no impact on PBC one way or the other. If you need it, take it.
Is it safe to take multivitamin tablets?
Yes, we have. I can feel our leaflet going out in the bare facts, actually. So actually there are a number of vitamin deficiencies that happen in PBC. So a good, simple multivitamin is probably a very sensible thing to do. Make sure that, all things being equal, you've got enough vitamin A, enough vitamin D. So a lot of people take it. It's very sensible.
Okay. With Urso, is it expected that liver functions are back to normal? If yes, how long after taking Urso?
So about 40% of people will return their blood test to normal. About 30% of people will have improved blood tests, but they're not normal. They're kind of below the levels we want to see. And about a third of people don't have enough of a response. So it's something like that. So about half the people who get a response to Urso, they kind of respond to it completely. It will take up to about 6 months. So it improves progressively for 3 months. It then tends to flatten out a little bit for the next 3 months. And then you're pretty much at 6 months where you're going to end up. And if it's enough of a response, great. If it's not enough of a response, nowadays people should automatically be thought of for second or then third line therapy at exactly a year. So this idea of we'll wait and see over a length of time. If you've not got the level of response you want by 12 months with us, so it's not going to change. So don't hang around and wait years. Now we should do second line therapy. Yeah.
I recently had a heart scare with the meds I take for aspirin, beta blocker, statin have a negative effect on my liver. Yes, no.
Sorry, what was that? Sorry.
I've deleted it now. Will the tablets taken have a negative effect on the liver for it was a heart scare. It was aspirin. Gosh, I haven't got the question now.
No, all fine.
Yeah, they wouldn't give them to you.
Yeah.
Really interesting with Lansoprazole. I have it plus Glimepiride, Succato, Benadryl before breakfast. Should I take the Lansoprazole before I take the others? Or ask my consultant about changing it for omeprazole.
I would, if you're taking a number of other medicines, I would change. I would just have any of the other your consultant will tell you that we use Lansoprazole because it's cheaper. It isn't. Okay, these are all generic. They're all cheap, and it's one of these bits of folklore. Okay, I think you were involved in this with a lady who was told that she couldn't have Urso-Folk. You were involved in this, Collette? She was told she was having trouble tolerating different brands of Urso, and our recommendation is always to take Urso-Folk, which is the branded one. And the reason that is because it's the one that's best tolerated, and it's the one that's always the same because it's a company that specifically makes it and markets it. Okay, and a lady was told by their doctor that you can't have the Urso-Folk because it costs quotes 6 times as much. Okay,
Nonsense.
And in fact, I printed out the relevant page from the BNF, which shows that it's in fact identically priced. So these myths are out there, and they are largely nonsense. And
I would also say to you that I met up with Falk at the conference last week, and the suspension, the liquid, if you can't follow the other ones, is quite good as well. It tastes a bit yuck. It's good. So last 2 points. Now, I don't think we should go into these, David, because they really are articles for the newsletter.
Yes.
Firstly, what new treatments in the pipeline, how far in the future till they become available? So I think, Alan, you're in the background, and Linda and Chris, I know you're all there. I think we should go around our medical advisory and see who we need to write about that, because we can't keep asking Dave all the time. Otherwise, he'll never have time to see his patients. And if I move to Hexham, I was looking on the thingy last night.
Nice place. It's a nice place.
Yeah, well, you might end up being a doctor. How awful would that be for you?
Just very, very briefly about that. So we're going to have new alternative second and third line treatments coming. I would imagine 2023 they'll be licensed. I think that's very likely. So those will be alternatives to obeticholic acid and to bezafibrate with strengths and weaknesses. There is research starting about when we use these drugs. Should we use them earlier? So same drugs used in a different way. We have probably 3 trials coming around itch with the first new therapy in about 2 to 3 years in terms of being available on the NHS. And then we are just embarking on the trials for fatigue. So the answer is there will be a pipeline of new drugs starting next year that will go for about 4 or 5 years, I would imagine. And all that does is give us more options to be able to look at combinations and alternatives with people. And these will be the sorts, no drug will come along that absolutely revolutionizes the disease compared to what's there at the moment, but they are drugs that will work for people where other drugs currently don't. So it's all about options.
Watch it, you're talking yourself into an article. They're all listening behind the scenes. Last one, and again, mea culpa, again, this is an article. Is a research in PBC transplant patients into why or why not PBC can reoccur. That's not for the airwaves today. And I don't mean to be disrespectful to this person. What information we want to give you is not in a 2-minute block. We want to give you a full explanation. You deserve to have that. So we're going, Alan's going to note that.
That really is an article. But just to say, we do see recurrence of PBC after transplants. Okay. There is work now to show that if you give Urso from the day after the transplant forevermore, it massively reduces the risk of that. It's kind of obvious, but that's now standard practice. So standard practice is to give preventative therapy, and most people simply never stop Urso. They just carry on straight on with it, and I would definitely do that. And I would never factor the risk of recurrence into a decision whether to have a transplant or not. If you need a transplant, you need a transplant. We can manage the risk of recurrence. That shouldn't stop you having a transplant. And anything you read about recurrence of PBC was before the routine use of Urso after the transplant, and that makes all the difference in the world.
And is that all 7 transplant units in the UK, David?
It's standard practice across Europe now.
Brilliant, excellent. Okay, everybody. David, you've no idea. You've answered loads and loads of questions. Thank you so much on behalf of all the members here. And I want to say too, what a joy it's been for me working with you. David and I have been working together, I don't know, 20 odd years, and always with the patient focus. He always listened to me, took me on board. I've been in car parks in the back of his car getting coenzyme Q10 to safely work for fatigue. It's been a great relationship, and what's been good about this, everybody, is that junior doctors have seen this and have bought into it, and he's a shining example. There's more news about David and the PBC Foundation to come shortly. Good news, lovely news, which is not for me to announce. Robert will do that next time. But David, if I do move to Hexham, I'll see you. Listen, I've seen a house. Don't go there. I'm fed up with the whistling going on down the road. So, but on behalf of every single one of us, thousands of us over the year, David, you're a joy to work with. You've done so much for me, the foundation, the team. You're a wee sweetheart. Thank you.
Well, thank you. And I'm going to carry on doing these if people still want me. The thank yous ought to go to you, because quite genuinely, none of us would be here without you. And I think it's amazing. You discovered actually your calling in life later on, which is that you, like me, are a frustrated chat show host. And I think you and we've just discovered a calling, haven't we? I mean,
absolutely.
I don't know.
We'll maybe do a wee special in our next liver conference.
Yeah, the Richard and Judy and inflammatory bile acid disease, you know. But thank you, Collette, for everything you've done. You know, I think, you know, right up to this very point with it all, I mean, it is a, you know, inspiration for everybody. And I know it's all in safe hands, and we, the community, but you can't, you know, you must do a comeback at some point for these things. You could be a celebrity guest.
Absolutely. We'll speak to the boss, but yes, I'm always open for anybody who needs me, wants me.
Yeah, and I think just for people, I mean, you know, I say this frequently. I think people watching this, I think you can tell we enjoy doing it immensely, and it's not a burden. It's the bit of the week I look forward to the most. And I think we all enjoy doing it. And I think, you know, it's been a horrible, horrible time with COVID, but this is one of the things that's come out of it that's good. And that we're going to continue with it as long as people find it useful, informative. People are very kind in what they say about it. But I think we've really hit on something which is valuable. And I think getting different people doing it, different views, different perspectives, different areas of interest. And I know from my colleagues on the clinical side, we all love doing this. And some of them are more nervous than others. So some of them are waffle on, you know, without too much.
I'll say no more of that one.
I know at least one person who prepares for it. I mean, prepares for it. Who's heard of such a thing?
But it's great. People like Vino, who's the itch is his big thing. His research has been fantastic. David, you've got a hard finish. Everybody in the background, thank you for your help, support, and teamwork. Everybody out there, bless you. I'm around to take helpline calls just a few hours a week, and I will come back and see you whenever I'm asked for. But Robert's in charge. He'll support you.
And Dave, thanks very much for agreeing to do 50% of my clinic articles for the next Bare Facts. Your deadline's 2 weeks on Monday.
Yeah. Oh no, just email me as usual.
I will do. Thanks a lot. Thanks to you both.
If we do get a comment in the chat box from Collette from Edinburgh saying, "Shut up and get a move on, Jones," we know what's going on.
Take care, everybody. Bless you.
Thanks, everybody. Bye-bye.
Bye-bye.
Thanks, Dave.
Okay, cheers.
See you again soon. Cheers.
See ya.